Standard assessments of adult visual acuity are based on verbal responses from the patient, while assessment of vision in infants and preverbal children requires alternate strategies. Over the next few minutes, we will be presenting a standard technique for measuring acuity in infants and preverbal children that is being increasingly incorporated into clinical settings. This technique is the Teler acuity card procedure, a method for behavioral assessment of grading acuity in infants and young children that was developed by Dr. David Teler and her colleagues at the University of Washington. A complete set of Teler acuity card consists of 17 cards. 15 of these cards contain square patches of black and white stripes ranging from very coarse to very fine. Each card has a small peephole in the center. A low vision card contains a large patch of 2.2 centimeter wide stripes, and a 17th card is a blank gray card. A label on the back of each card indicates the grading size of that card.
Hi, I'm Jan, and I'm going to be...
In most testing, the cards are presented from behind a screen to eliminate as many distractions as possible. Included with the screen is an eye shield that is suspended in front of the screen to mark the test distance, and also to prevent the person holding the child from seeing the test gradings and giving clues to the child.
And I need to see how each eye works by itself, so I'm going to put a patch on and do one eye at a time, and the procedure should take probably about 10 or 15 minutes.
Infants between birth and 6 months of age are tested at 38 centimeters unless they have very poor visual acuity that requires a nearer test distance. From age 7 months to 3 years, the test distance is 55 centimeters. After age 3, the test distance is 84 centimeters.
You ready? Are you ready? Jumping. Okay, we just gotta make sure we're looking where we need to.
It is useful to have a collection of hand puppets, bells, and colorful, noisy toys to attract the patient's attention and to keep the patient interested in the test procedure.
Good job. Okay, very good. Here comes the next one.
The patient is held or seated alone at the correct test distance from the acuity cards facing the tester. The tester is seated behind the screen with the cards stacked face down in order from coarser to finer gradings. The tester attracts the patient's attention so that the patient looks straight ahead, and then the tester holds the card up to the rectangular opening in the screen. When testing begins, the tester should show the patient a relatively coarse grading that is visible to virtually all normal children of the child's age. Then the tester presents the blank card to see the patient's behavior when gradings can and cannot be seen. The width of stripes on the initial card varies with the age of the child. After the initial presentation, the tester should make a judgment about the location of the grading and then rotate the card to check that the patient's response changes appropriately when the grading location is changed. If the patient's responses are clear, the tester can look at the front of the card to check his or her judgment against the actual grading location. If the patient responses are unclear, the tester should present the card several more times until he or she can make a confident judgment about the grading location or can decide that the child cannot see the grading. Finer gradings are then presented and repeated until the tester can select the finest gradings that the patient could see. Each card should be presented at least twice, once with the grading on one side and then the card turned 180 degrees so that the grading is on the opposite side. As the patient nears the acuity limit, indications that the patient sees the gradings often become subtle, requiring that these cards be presented to the patient several times. It is often useful when testing near the acuity limit to show the patient a card containing coarse gradings. This will restore the child's interest in the procedure and will establish that the child's lack of clear response to finer gradings was due to his or her inability to see the grading and not to a general lack of attention or fatigue. The tester uses a variety of behavioral cues, some of which depend on the child's age and developmental status, to decide whether the child sees the gradings. These cues may also give an indication of the relative size of gradings, such as whether a grading is well above or near the acuity limit. For example, a very young infant may continue to fixate a coarse grading even when the assistant turns the infant away from the grating. The infant's response to a grating near or at his acuity limit, on the other hand, may be much more subtle. This may consist of a slight preference for a grating side or a widening of the eyes upon viewing the grating. When the infant cannot see the grating, there is a tendency toward more random scanning of the card and screen and a rapid loss of attention. With children between 5 months and 2 years of age, the most useful cue is the child's initial eye movement when the acuity card is placed against the opening in the screen. This means that it is important for the tester to be looking through the peephole as the card is presented so that the initial eye movement is not missed. It is also important that the child's gaze be centered before the card is shown, so that the child will have an equal opportunity to respond to the grating regardless of which side it is on.
Could you point to the stripes for me?
Children older than 2 years can often be taught to point at the grating. With normal 2 to 3-year-olds, the pointing may not reliably be to the side where the grating is located, but the tester should nevertheless encourage pointing. It keeps the child's attention on the test stimuli, and the tester can use eye movements to judge whether or not the child saw the grating. When presented with a grating near their acuity limit, young children may say that they cannot see any lines and may be unwilling to point. However, they may still reliably fixate the side of the card where the grating is located.
And the next one. How about here?
Some children may not respond to any acuity cards when they are presented behind the screen, even when the child is tested at the near distance of 38 centimeters. If this happens, the tester should try testing the child without the screen. To test without the screen, the tester sits in front of the child, carefully measuring the test distance. Then the tester shows various cards until an acuity estimate can be made.
Okay, let's try a bigger stripe. You ready? Here we go. 1, 2, 3. Ta-da! Stripes. There you go. All right. Okay, I'm going to move up a little closer.
Initially, the tester tries a test distance of 38 centimeters. If no response is obtained, the tester moves into 19 centimeters. If no response is obtained at 19 centimeters, the tester will try 9.5 centimeters. The .23 cycles per centimeter or low vision card is intended to extend the lower end of the test range for low vision patients. The overall patch size of the grating is increased on this card. The low vision card is not part of the original series, and due to a change in grating size may not give acuity values in the same scale as those in the original series. Conversion to cycles per degree or Snellen equivalence is not recommended using the low vision card. Simply record that the low vision card was seen on the chart.
Where'd those stripes go? Here they come.
In the very low vision patient who does not respond to static gratings, it is sometimes possible to elicit optokinetic nystagmus by moving the low vision card in front of the patient. If an infant or child has horizontal nystagmus, it may be helpful to hold the card vertically without a screen. This allows vertical eye movements and head position changes in response to the grating to be distinguished from the horizontal nystagmus.
There they are. I see you looking at the stripes.
To record the data, find the patient's age on the graph, find the test distance on the template, find the cycles per centimeter value on the threshold card of the template, use the template to plot the result on the graph. Results that fall between the two solid lines are within the normal range for binocular acuity for the child's age. Points that fall within the dashed lines are within the normal range for the monocular acuity for the patient's age. In conclusion, we have demonstrated the use of acuity cards in infants and young children. The acuity cards are intended for the use of trained eye care practitioners and their assistants. They are not a replacement for a thorough eye examination. The acuities obtained should be interpreted in the context of the overall clinical presentation and the results of the eye examination. It is certainly advisable to retest any child whose acuity results are inconsistent with the overall clinical impression. If possible, the retest should be done by a tester who is unaware of the results of the first test.